number of the incidence of the risk, or make, when the risk occurs, the severity of the problem smaller. So there are a couple of definitions that they introduce here. First is hazard. Hazard is what can go wrong. In principle, hazard can be everything which has to do with the product, the patient, or the prescriber. And what can go wrong, and you have to think about it in advance. And if you think in advance, you can do a much better job than when you're only reactive. And we go into that a bit also. So what can trigger it, and if it happens, how bad is it, and how often does it occur? Risk assessment is so what? Should I worry about it? If it's something that is absolutely trivial, maybe I should not worry about it. If it's something that is important either for the patient or for the company or both, then you should be interested in diminishing this problem. And then risk management is how can I improve this situation? When you look at these definitions and ways of life and policy, you understand that risk management is not exactly the same as drug safety. This risk management is not only something that occurs in the pharmaceutical industry. The pharmaceutical industry is quite late in implementing risk management. Next slide. This slide shows how companies try to evolve over the period of their lifetime, and especially also in the way how they should approach the environment and the way they are approached by the environment. So in the beginning there was, you made a drug, you brought it to the market, you didn't care. Maybe there were some spontaneous reporting systems, and if something happened, you put it in. If it was very dangerous, you put it in the label, and that's it. That was a very no-kill culture with regressive, and the motto, yeah, okay, accidents happen, so let's not worry about it. Then we came into the blame culture, where they do worry about it when it happened. And they want to prevent, at least in the future, to have a similar accident, and but not thinking yet about preventing all accidents. This blame culture is also a bit a problem, because then within the company, a department, or even worse, a certain person is blamed, being the cause of this specific problem. Then we go into the compliance culture. That is already more mature companies. They try to prevent incidents before they occur. They have regular auditing of their procedures. They have procedures. They look at causal investment, and they have a way of life when they try to prevent incidents before they occur. Then we have the ownership culture, which is really proactive, and that is that within the company, also due to procedures, but also due to training and education, people feel responsible for the part of the system in the whole drug development and bringing things on the market, and they feel a kind of ownership on that. And in the ownership, they try to do their best in order to make the result as good as possible, and that it's not only then results in how much do I sell, and that counts from my bonus, but also what is the most efficient and best way to prevent damages. And then, not so many companies are there yet, is the way of life when risk management is at the core of the entire business process. And one industry that is theirs, for instance, the airplane industry. They started with that already a long time ago, and some of my slides are also stolen from the airline industry. So companies should at a certain moment go from a no-care situation, a regressive situation, a reactive situation, to a way of life where risk management is part of everybody's business and can be discussed at all levels. Next slide, please, Donald. This is the risk management cycle. I showed it also last Tuesday, but in a different form. This is more extensive. And so what you try to do, you start with assessing key risks. We are measuring the likelihood and the impact of the risk, and we also try to rank risks, and I will come to that a bit later, how we can put risk in a certain ranking so that it makes sense from a benefit risk point of view. We set the desired results, where do we want to end, and then we develop options where we can reach what we want to strive for. And then we select a strategy, implement the strategy, monitor the strategy, and at a certain see whether the strategy is effective. If not, we try to adjust. So this is the entire risk management cycle, where mature companies and people that really like to make fun out of their job should go into. It's integrated risk management and continuous learning. Next slide, please. Okay, we talked already a bit about hazards, something that can be an inherent property of the product or a condition of use. It can have to do with the patient that is receiving, in the end, the compound, his pharmacogenetics. Not every patient is treating a drug and his body is metabolizing the drug in his body in the same way. Comorbidities, which can have an effect of metabolism or on the effect on benefit and on risk. And sometimes your intended or your hazard is even an intended property of the compound, if you want to kill cells, for instance. A trigger can be some event, a condition that has the potential to cause a hazardous condition and results in a negative outcome. And then the risk in the end, if everything goes wrong, is a clinical outcome when the hazard and the trigger are combined. And how often does this occur? What is the probability of the occurrence, so the incidence? And what is the worst case scenario? What is the worst case severity? And that is what we want to manage in risk management. Next slide. This is the airplane industry, and also sometimes called the Swiss cheese model. I'm from Switzerland. That's not the reason why this slide is in, but it always gives me a very, very good idea when and why something can go wrong. And many times things do not go wrong. That is also, of course, a fortunate circumstance. So we have a hazard, and the hazard we can try to minimize, or with prescriber knowledge, with pharmacist knowledge, with patient risk factors, pharmacogenetics, the way how it's administered, with education, with monitoring. But of course, all these mechanisms have a gap in their defense. The hazard can be that drug A is prone to interact with drug B. So the second model shows that drug A is given together with drug B, but because of the knowledge of everybody and some other mechanisms, the ADR does not occur. The risk is that when all the holes in the cheese or in the different layers come together, finally you end up with a situation that you don't want, a development of an adverse drug reaction with a certain severity, certain probability, if all the failure modes indeed are wrong. And the controls are then aligning in an unfavorable way, and then the problem starts. So what you have to know is everything about the hazard, everything about the trigger, and then with risk minimization, risk management, you can try to prevent this, all the holes in the defense layer come together. Next slide. The European Union, and which has been quickly picked up also by the other regulatory authorities, gave a very clear guideline on what they would like to know about each risks. And they talk about identified risks and potential risks and missing information. And we went in those definitions in the webinar of last Tuesday. So the probability is the frequency. You have to write down when you, in your risk management plan, you talk about the risk, whether it's identified potential risk. You talk about the frequency. You talk about the effect and the severity, both on public health and an impact on the individual patient. Something can have, for public health in general, a beneficial effect. For instance, with vaccines, when you try to immunize an entire population, but the impact on an individual patient can have a major effect. And then for the individual patient, the public health impact doesn't matter so much because it's him or your mother or your grandmother that is going to suffer. And so the hazards and the trigger that you also have to describe in the risk management plan. What are the risk factors? Which patients are more vulnerable? Which is a dose that could be a problem? When could be an at-risk period? For instance, when you give it, the most well-known is during pregnancy or not pregnancy period is then the pregnancy. But it can also have to do whether you take something before the meal, during the meal, or after the meal. Additive or genetic factors, if you take it together with other compounds or food. Preventability, is it possible to avoid? Is it possible to prevent? Is it possible to detect at an early stage that something is going wrong? The potential mechanism, and then in the end, the evidence of the source and the strength of the evidence. And depending the strength of the evidence can make a potential risk an identified risk. This you all have to describe in your risk management plan. This is also what regulators in Japan, Health Canada, Australia, the bigger countries in South America, and of course the FDA like to see. Next slide. These are the 6 hazards that has to do with a problem when the trigger and the hazard comes together and forms a risk. Is of course the patient. We want to treat the right patient. It's the product. There can be something wrong with the product, or a product can be dangerous. The profile of the end user, that can be either the patient itself or it can be the prescriber. Of course, the morbidity, the patient can have loads of other diseases that may interact with not only indication but also with the product. How the product behaves in the body, the metabolism, and which part of the body are affected in the end. Next slide. Companies know many times everything about the product, but they don't know so much about patients, and they don't know so much when an ADR occurs in the liver. They might not have the experience in liver disease, so you need somebody who knows about that as well, next to epidemiologists, of course. Here's an example, a simple example. The hazard is that there's a patient, and it's male. He has a BMI of 32, so he's a bit heavy. He has a slow CYP3A4 metabolizer, doesn't know why. He receives a calcium channel blocker for hypertension. It can also be that he is a slow CYP3A4 metabolizer, but he doesn't know and the environment doesn't know. So at a certain moment, this patient sees that grapefruit juice is healthy, and he's going to drink quite a lot of grapefruit juice daily. And the grapefruit juice takes up all these CYP3A4 enzymes. He already has not so much, so this calcium channel blocker plasma levels go sky high, which can lead to severe hypotension, severe bradycardia. So the probability and the severity, if you go in the worst case scenario, it has a major impact on the patient. And it is something that if you know that your product is metabolized over CYP3A4, and when a high plasma level might lead to a danger. You see that many times with psychotropic compounds, antipsychotics, antidepressants, and so on, that the plasma levels can be so high that the patient actually gets a fatal ADR that happens. So you want to prevent that, and it can be that you either try to, in advance, to look at patients that are slow metabolizers. You can do a gene test. Or the other hand, you say, please be careful when you go drinking grapefruit juice. And in psychiatric patients, please be careful when you suddenly stop smoking, because smoking is also has an effect on the genes, which has an effect again on high and low plasma levels of psychotropics. So that's a simple risk scenario that is preventable. Next slide. Here's a matrix. How can we rank risks? This is a matrix that you can use. It's actually not so complicated. On the left side, sorry. On the left side, you have a bar with the, or an axis with the how often something can occur, whether it's very rare or where it happens in more than 1 in 10 patients. And on the other thing, you can have the severity of a certain adverse drug reaction, whether it's a transient or it goes away without anything, any treatment, is well tolerated, or in the worst case, it can be fatal. Next slide. The next slide shows you the same ranking, and where you and regulators and clinicians agree that if it's in this band, the benefit-risk ratio is okay. So it's a so-called risk tolerance boundary. If the risks are within the green, it is okay. It's something that is manageable. Next slide. Next slide shows you a cancer product, an example of a cancer product. Blacks are identified risks, the yellow spots are potential risk or missing information. And you see that some are in the green and some are outside of the green. And what you want to try to improve is next slide. Visual risk management procedures. So risk minimization is the reduction of incidence, and risk mitigation is reduction of severity. That those risks that are outside of the safety boundary goes in the safety boundary. And that is what you try to do with risk minimization, risk management. Next slide. Regulatory authorities love these graphs. If you have a graph at a certain moment in your risk management plan where you can put something like these spots in, they highly appreciate that. So when you manage, then the benefit-risk profile is favorable. All risks are more than less controlled and within the risk tolerance boundary. What you have to be careful of is that risks that are just on the edge of the risk tolerance boundary might jump into the area where the risk profile is not favorable anymore. And that is something what we call preventive risk management. So it looks safe, but at a certain moment when the incidence increases or when the severity increases, it goes outside of the boundary, and you have to try to be careful for that kind of ADRs when they occur, where there's an increased frequency or increased severity, etc., etc. Next slide. So, what have we gained with this tolerance, with this ranking? We made a definition of those risks that could be acceptable, of course, given a defined benefit of the drug. We look at the risks that are beyond our tolerance, and those are the risks that, if they're not controlled, they can yield an unfavorable benefit-risk profile. And we want to try to manage those risks. And of course, from the potential, we want to know why they are potential and why they are not identified. We, of course, have to know which measures we need to apply to improve these risks. And what is the theoretical improvement once we have to achieve to obtain a favorable BR profile? We want to have it, but we also want to maintain it. And what I just said, one of the things you have to look at is to look at the risks that are just below the risk tolerance boundary and see if they're not going outside. Next slide. If you look on the identified versus the potential risks, then in principle identified risks are a minor issue. Because there are no surprises, there is a clear causality. The risk can be defined by clinical meaningful outcome, and you can prevent it by telling the patient, telling the doctor, in your educational materials, or just in the label, which patients should not get this, and if they get it, what they should do. And then, but in principle, there's no surprise. With potential risk, there could be surprises. A potential risk can be something, I gave the definitions last Tuesday, but just to repeat quickly, a potential risk is something that you have seen in a non-clinical program, in the preclinical program, but not in the clinical trials. It can be a signal, but the frequency is very low, or a causality assessment is difficult to give, and you still have to take the worst case scenario. And those are the kind of possible potential risks. So it can be that also that you have a wrong a priori assumption of the effect, of the probability that it occurs, and the severity that it occurs. It can be that the so-called optimism bias, this will not happen with our compound. Also the head in the sand politics, we first need proof and then we do something. So for the moment when we don't have proof, we don't have to worry about it. That is something that is often, you hear that often in companies from certain departments or certain individuals, that they try to behave like that. And then, of course, decision-making under uncertainty is something that nobody likes to do. And people feel not happy about that, and still it's something that is necessary, especially when you run into a very unexpected risks, which comes close to a crisis. You have to make sometimes very unpopular decisions, and you have no clue if it's on what you really base it. But the only thing what you can do is prevent further damage. Next slide. Then the missing information. The missing information has to do with, for instance, interactions with other compounds. You have investigated some of the other drugs in your preclinical and clinical programs, but many times patients do not tell what they take. They do not say what they got from their siblings or from their parents or grandparents, or the neighbor who says, oh, you have pain, I have something that worked with me many years ago, still here, you can have it. And of course all the over-the-counter products that the doctor who is prescribing the specific product doesn't know about. Then you have racial differences. We know that there are major genetic differences between different races. Japanese population is very famous about that. They are more vulnerable for adverse drug reactions due to a higher plasma level, because there's a much higher incidence of defect in certain genes in the CYP metabolism. And of course, you can be pregnant, you can have another illness, etc., etc. All that is information that you don't know about yet, and what you want to look for in your pharmacovigilance program is to identify triggers, identify effect, identify probability and severity. So missing information should become knowledge. Next slide. So now we go to setting the desired results. So before we're going to make a risk minimization or intervention or a specific pharmacovigilance activity in our plan, we of course have to define the goal. What do we want to achieve? And that is something you just have to think about together. It can also be that the same risks, but with different products, might have different risk management goals, depending on the benefit-risk profile. If you have a benefit-risk profile, or if you treat, for instance, a patient with cancer, normally the patient and public health accept higher risks than when you treat something for a common cold. You can have a pregnancy prevention plan, and it depends what you might like to achieve. If you really don't want any pregnancy to happen, you have to educate, or you have to put in mechanisms that somebody who's pregnant or planning to become pregnant has no access to your drug. It can also be that you do not know enough about it. You say that you prevent, but if you get a patient who is pregnant, you follow up to delivery of the baby to see if everything went okay or not. And the definition of the goal of a risk minimization activity dictates the choice of the strategy and how to implement that strategy. Next slide. So here you have a couple of options. For instance, if you want to prevent the use of certain compounds in certain patient groups, or make sure that the product is rightly administered and prescribed. First is educational activity, and those are activities that are characterized by dissemination of information. So you want to educate and you want to communicate, and actually what you also want to do is to change behavior. I'll come to that later. Then there's enabling activities. That is something that requires active participation of the target audience to minimize the specific safety concern or the risks. There are antipsychotics, and for instance, with clozapine, the motto is no blood, no drug. You first want to know what the blood values are, certain blood values are, before you give the compound. That needs an active participation. You can also say that when you have education material and you disseminate that, you communicate that, and you request the doctor that he gives the same education to the patient and he's documenting proof of that, then you're already enabling. And then, of course, control-based, which is a system that either the company or the regulator prevents that a certain drug is given when not all the requirements are being fulfilled. Next slide. Here's another hypothetical drug, and that is what you can put into your, as an example, what you can put in your risk management plan. For instance, you have an identified risks, and that is urinary retention. Your goal is to have further characterized the urinary retention in association with the drug. For instance, time to onset, specific population, interactions, assessment on long-term safety, and of course you want to avoid complications due to the retention. What you can do, and here we put routine and additional pharmacovigilance activities together. Routine PV, that is that you monitor your spontaneous reports, you do some education, and you try to get as much information as possible, and that information is then, with your risk minimization activity, is communication either in the label or with education materials for patients and the healthcare provider. If you want for urinary retention, you want more information than for other specific ADRs. So you have a guided questionnaire. Every time when you have a urinary retention, you ask more questions. You have a more extensive follow-up. You ask different questions. That is still seen as routine pharmacovigilance, but it gives you more insight and more information. What you can also do, and then you come really in additional pharmacovigilance plan, that you set up a prospective epidemiological study. That can be a registry, it can be a database study, where you follow the patients that are taking the drug, or you follow the patients that have the target disease, and you see what's going to happen over time, and you try to analyze all the information that you get from that. Then there can be with this product also potential risks, and that has drug-drug interactions with CYP2C8 inducers or inhibitors. And what you want to achieve is to avoid serious adverse events due to co-medication with this compound. That can be with routine monitoring of adverse events in the safety database, and in the end that can up with warning and on co-medication or more specific warnings, and it can also end up with education material, for instance, or in the worst case a very clear contraindication between two compounds. Then you can have a third safety concern is missing information in pregnant and lactating women. Didn't show the compound teratogenicity in animals, but you have no clue what happens in real life, so you warn patients of childbearing potential about these unknown risks. And your objective is to assess the risk for that specific patient population. Of course, within your mind that you want to take action before something goes wrong in a very big number of cases. We don't want a second thalidomide story. or Accutane or whatever. So you carefully monitor your AA database, you set up a pregnancy database, which is part of your AA database, and you do a regular review of data with defined thresholds. In the end, your risk minimization activity is you can, of course, you put in the warnings and precautions that the drug had not been tested in pregnancy. It should only be taken if benefit outweighs potential risks. That is, of course, always very vague, and you get questions from doctors. Yeah, okay, I know the benefit, but since I don't know the risk, how can I outweigh the benefit risk potential? And I must say that also I never found a real good answer to that, except that when the patient is really suffering, and this is one of the few drugs that helps, then I think the benefit outweighs the risk, especially since no teratogenicity has been seen, but I want to know the outcome of the pregnancy. Next slide. So, implement the strategy. If you do more than routine, what is required, consider who needs to be involved. This is in the company. Who needs to be involved, how much planning time is required for global and local functions. You can think of the most beautiful global functions, but when you forget about your local people, nothing happens. What is the impact in resources and budget? And of course, in the company is important who is going to pay. Since pharmacovigilance never has budget, it probably needs to be paid by another department, which is the marketing department, and the marketing department is very many times not so eager to put in major risk minimization programs. But still, over time, you can convince them that it has only a positive business impact. What is also important that you have to look whether a global strategy doesn't violate local regulations, because we have seen that something that is being proposed as a global strategy is not possible in a certain country. One of the things is, for instance, limited access of the compound to certain patient groups. That is, for instance, in Europe, very difficult to achieve. Implementation and planning must be in parallel, and it has to be in parallel with the development of your risk management strategy. Next slide. You can show the whole slide, thank you. This is a bit difficult to read. It's about failure mode and effect analysis, FMEA. And actually, if you print it out when you get the presentation from Synowledge, then you can read it better. But it's about ideal behavior, and in a nutshell, it is that the right prescriber gives the right drug to the right patient. That's the ideal behavior, and that's what you want to achieve. And you want to have limited off-label use. You want limited medication errors, and but if the right patient gets it, then it would be great. And then the other parts in the table show the goals, the hazards, the failures that can be made. Doctors not trained. I've seen crises because the company trained the doctors, but doctors that were not trained used the compound as well, which led to pretty big disasters, both for the patients and for the company. So you have to identify tools that may mitigate your risk, etc. Read this slide when you have it on your desk, printed out, and then it's easier to read. But it's everything about failure mode and effect analysis. Next slide. Then evaluation of effectiveness, and it's also something that you're obliged to do these days. There's in Europe an entire module devoted to it, how to measure effect, and how to do that. I will give a short overview in the next slide when that's possible. Anyway, there are two things that you have to realize here as well. There's always the advocate of the devil, of course. If it doesn't occur, the event, are we indeed effectively managing the risks? And if it does occur, have we failed? I give you a very quick example. There was a drug that gave hypersensitivity, but only after 14 days the drug was given. And so everybody said that not only, but the majority of the cases were after 14 days. And the reactions were quite severe. the company and the authorities decided that they should not give prescriptions longer than 14 days. They should reduce the pack size to 14 days, and the patient, when they came for repeat prescriptions, should wait for a while before they got it again, or they should be very carefully monitored. All very justified risk minimization activities and a great plan. The only thing is then, of course, the hepatitis sensitivity reactions that did occurred all within 14 days. And this then be managed completely, but the event still did occur. Next slide. Authorities also many times ask for baseline data. The problem is that you do not have always baseline data. And when you have a potential risk and you put a new measurement in and they say, can you compare with the previous situation? Most of the time you can only compare with spontaneous reports. And spontaneous reports are, of course, influenced by the amount of information you give around it. So an implementation of educational tools to prevent an ADR in the beginning leads to an excess reporting of the ADR that you want to prevent. Okay, if we evaluate effectiveness here, we want to educate, so we want to see, did my risk minimization tool reach everybody? Is the target audience where we sent it to, did they get it? Did they look at it? Are they aware about it? Do they know it? And do they comprehend it? Is their behavior changed? Because that's what you want in the end. And then, of course, did this behavioral change the occurrence of the safety outcome, of the ADR outcome, so that the benefit-risk balance is positive again? How can we measure that? Next, click. We can measure that by, of course, if you mail something, you have mail house metrics. We sent it to that, how many did return? You can do a survey on the stakeholders, did you get it? You can also ask them with a survey research, if they read it, if they understood it. And you can also say, the last 6 patients that you treated with this compound, can you describe the patients? And then you know whether there's some behavioral change, yes or no. And in the end, you can set up a patients registry, epidemiological programs, a PAS, post-authorization safety study, patient-reported outcome diaries, etc., in order to measure that your risk minimization procedure had effect. So, when you put in a risk minimization procedure into your risk management plan, you have at the same time have to tell how you're going to measure the effect of it. Next slide. Next slide is also something that is easy to be read by yourself. It's an evaluation method according to the risk management tool types. It is comes from a publication by the International Society of Pharmacoepidemiology, of which I was president a long time ago, before this was published. And it tells you the level of evaluation concerning coverage, awareness, knowledge, change of outcome, etc., and all the ways how you can measure that. It gives you a very nice short graph in a nutshell, everything that you can, almost everything, the methods that you can need for the evaluation of your effectiveness. I think that's my last slide, Donald, so I'm happy to give back to you.
Great, thank you, Jan Willem. That's perfect. We've approached the Q&A section of today's webinar, and before we go to that, I'm going to give you maybe 30 seconds or a minute just to put any questions into the chat window. Once again, I'm just going to draw your attention to the chat window by posting something in there myself. You can see it coming up. So while you're putting in those questions, and thank you to everyone who's put them in so far, I'm going to give you a 30-second overview of who we are, for those who don't know us or who weren't at any of the events previously in the week. So Synowledge was acquired by Bioclinica quite recently. That was in October. So Bioclinica is a leading provider of specialty outsourced clinical services and Synowledge fits under the Bioclinica eHealth Solutions division. And under that division, we offer pharmacovigilance for drug safety, regulatory affairs, and relevant IT services. I don't intend to go through everything on this slide today. You can look through it, and we'd welcome any conversation you'd like to have on our services in these areas. As I mentioned earlier in the week, the one area that we're seeing significant growth is in the drug safety area, where obviously we are providing the traditional on-premise model, but the big growth area that we're seeing is pharmacovigilance as a service, where we manage all aspects of pharmacovigilance on behalf of our clients, from application management, hosting, all the way through to business process support. So that's a big growth area that we're seeing. That's the pitch. That's the end of the pitch. So I'm going to now to proceed to the Q&A section of the webinar. So there's still questions coming in as I start. So I'm just going to start with the first one, and then I'm going to go back and just review the questions that are coming in. So Jan Willem, I'm just going to unmute you so you can talk. So I'm going to ask you the first question. This is actually for someone who's called in, so I don't have a name. So I'm just going to call it from anonymous. So where do I find epidemiological background, and in brackets, incidence, prevalence, etc.?
It's a good question. That is something where people always start to struggle with. Well, the answer is relatively simple. You start with the textbooks. There are many textbooks on diseases, on incidences, and prevalences in textbooks. The second thing is that you can screen the big literature databases on epidemiology, on the incidence and prevalence of certain adverse events. When something goes wrong, you can look in literature on interactions, and a number of articles will pop up. So your first two main sources are A, textbooks, 2, published literature. The third that you can go to, and that depends a little bit on the topic that you like to investigate. If you can go into national health statistics on deaths, on pregnancy, on cancer incidence, etc., etc. And then there are certain national health supported registries, for instance, renal disease, patients with certain diseases, etc. So start with your textbooks, then go to the literature, and then go to national health statistics.
Okay, thank you very much. Second question comes from Ryan, and the question is, what to consider when choosing a risk minimization tool?
What to consider is, first of all, what you like to achieve. And if you want a null risk situation, or you want to bring a risk to a lower bigger threshold, so it does not occur so often, or the severity is much less, that's what you all have to consider. What do I want to achieve? And then you can look at the tools. But the first thing is always, what do I want to achieve? Where do I want to end up? And that makes the easier search for your risk minimization tools. Also, risk minimization tools and effectiveness of it are published sometimes, especially when it worked. The negative publications are a bit less. But what you can do is try to find also in the literature, if I want to minimize this specific kind of risk, what can I do? And of course, you can consult people who doing these things on a day-to-day basis, consultants.
Okay, thank you very much. And the next one is from Julia. What kind of PASS are possible, or PASS? What kind of PASS are possible?
A post-authorization safety study is a program where you want to further clarify what exactly is going on in order to have a better understanding on the problem and on the population that is getting the problem. It can go from all the epidemiological studies that are there can be a pass. For instance, a cohort study, a case control study, a case cohort study. We can do a webinar on epidemiological tools if you like. Those are all possible. Further, a simple clinical trial. You should not have a clinical trial with a few patients and many outcomes. You should have a clinical trial with many patients and few outcomes, so-called simplified clinical trials. And then in the epidemiological programs, you have registries, databases, and things like that. Many times, most of the passes that I know are either simplified clinical trials or database studies or analysis of large databases. Can also be spontaneous reporting databases like Wikibase of the WHO or the FDA database or the Eurovigilance database, or setting up a registry. And a registry is either patients with a certain disease or patients taking a certain drug.
Okay, great. Thank you very much, Jan-Willem. That is all the questions that we have got so far. So if anyone's got any other questions, if you want to put them into the chat window now. If not, we will call an end to today's webinar. But if you have any other questions you think of after today's event, please do feel free to send them through to us. We'll happily respond to them. Jan-Willem will review them over the next 24 hours or so and come back to you with a response. So it looks like that's it in terms of questions. So just want to thank everyone for coming today. Thank you very much. It was great to have your attention and also for your interest in this Risk Management Symposium event throughout the week. A recording of today's webinar as well as the webinar on Tuesday will be available on our website. The one from Tuesday is currently available on our website. If you have any suggestions for future events or future topics that you'd like us to look at, please do send them through. We'd love to hear your feedback. And also, if you'd like a one-on-one conversation with a member of the team, Jan-Willem or anyone else within Synowledge, please do reach out to us at the numbers on screen at the moment. Or alternatively, you can send us an email at info@synowledge.com. So thank you, everyone, for your attention today. Bye-bye for now. Bye-bye.